Thank you for the opportunity to share my work with you today. So my research is really focused on looking at blood pressure patterns in children with chronic kidney disease. So a little bit of background. So in pediatric, in the pediatric hypertension population and in our practice, we're frequently using ambulatory blood pressure monitoring. And so this is an example of what this machine looks like. So it's a machine that's worn in the child's home environment to assess blood pressure intermittently about every half hour for a full 24-hour period. And it really is becoming the standard of care for pediatric hypertension. In fact, now our updated guidelines are recommending the routine use of this monitor for management of blood pressure in pediatric chronic kidney disease patients. And what's really neat about ambulatory blood pressure monitoring is that it allows us to capture diurnal variations in blood pressure and gives us a wealth of information on blood pressure patterns in our patients. So this is an example of what a data strip would look like for a patient. And they wear this monitor again for a 24-hour period. You can see here in green the heart rate, in blue we have their diastolic blood pressure, and in red the systolic blood pressure. And what's notable here, visually you can appreciate that there's this dip in blood pressure, and this is presumably during the time the patient was asleep. So this term, blood pressure dipping or nocturnal blood pressure dipping, was actually first coined in the 1980s by O'Brien in The Lancet. And basically, they identified that there was a subgroup of hypertensive patients who had this blunted decline in blood pressure. And this group had a higher frequency of stroke, despite no other differences in other demographics or in their blood pressures, daytime blood pressures or medications. So there was no significant difference in as far as age, sex, weight, and the medications that they were on. So this sparked a lot of interest in this area, and there is a lot of literature in the adult world looking at nocturnal blood pressure patterns. So this is an example of what are the different patterns we may see. So first is like the normal dipping pattern, which is when blood pressure goes down by both systolic and diastolic go down by at least 10% at night. Here you have a non-dipper, so the blood pressure at night is higher than would be expected. So there's this blunted dipping, and in fact there's reverse dipping when actually blood pressure goes up at night as compared to daytime. And what we know is that the non-dipper and reverse dipper patterns have been associated with more rapid decline in kidney function and increased left ventricular hypertrophy in the adult population. So specifically, there's the Jackson study where they found that reverse dipping was significantly associated with left ventricular hypertrophy. In a different cohort, an adult hemodialysis cohort, non-dipping was significantly associated with higher left ventricular mass index and greater left ventricular hypertrophy. And these are all sort of surrogate biomarkers for cardiovascular disease. And in a cohort of adults with elevated blood pressure, the non-dippers who were followed over time actually had a greater decline in kidney function for a follow-up period of about 3 years. So what do we know about non-dipping in children? So in children, we've actually adopted the 10% threshold for defining non-dipping, and we adopted that from the adults. So we define non-dipping as a less than 10% decline in systolic or diastolic blood pressure from daytime. We do have small studies in children showing associations between dipping patterns and surrogate cardiovascular biomarkers, such as carotid intima medial thickness and pulse wave velocity. And we know that some literature has identified in children that risk factors for non-dipping in the general pediatric population, obesity and obstructive sleep apnea have been identified. Some questions were really kind of taking the idea of non-dipping and trying to understand what does it mean for our high-risk pediatric patients with chronic kidney disease where blood pressure control is really important. And kind of in thinking about this, trying to understand what are really what really makes a non-dipper and what are the factors here at play. And so there are different axes that are thought to affect dipping patterns. One of them here is actually sodium intake and excretion. So we in the adult literature, higher sodium intake and impaired daytime sodium excretion has been associated with blunted nocturnal blood pressure change. There's thought around, the autonomic nervous system and its role, that higher sympathetic tone and lower parasympathetic tone also may be contributing, and that there are a variety of other catecholamines and abnormalities in catecholamine profiles which have been not well characterized, have been hypothesized to play a role as well. So lots of factors here. But my first question is really, well, what are the risk factors for blunted dipping or lower nocturnal blood pressure change in children with mild to moderate CKD? It's important that we identify these children. And our hypothesis is that based on our research in our literature in the adults, that higher sodium intake and greater proteinuria would be associated with lower nocturnal blood pressure change in children with mild to moderate CKD. So we evaluated this using a really unique cohort. This is the chronic kidney disease in children cohort, the largest cohort of children with CKD in North America. So we have children ages 1 to 16 years with a modified Schwartz eGFR of 30 to 90, and they're followed longitudinally for average about 5 years here. And exclusion criteria: history of dialysis or transplant, malignancy, structural heart disease, which is important, and certain genetic syndromes. So using the chronic kidney disease cohort, I obtained all subjects who had a baseline ambulatory blood pressure monitor completed along with their baseline echocardiogram. And we have looked at that data and identified dipping patterns. So this is the distribution of systolic and diastolic dipping from the baseline ambulatory blood pressure monitors, and this is in 714 of these children. And so notable here is that the mean for systolic dipping is around 10%, and the mean for diastolic dipping is actually much higher, around 16.7%. So this is despite us using the same threshold to define non-dipping in children, both systolic and diastolic parameter at 10%. So this is interesting here. And then when I went ahead and split the groups by dipper and non-dipper as currently defined using the 10% threshold, and looked at the differences in baseline characteristics between the groups using independent t-test and Pearson chi-squared. So here we have 298 non-dippers, so about 40% of this group are non-dippers as we currently define these. And you can see here that there's no significant difference in age, birth weight, gender, or actually their measured GFR, in fact, was there no significant difference there, or ACE inhibitor use. What I've boxed here in red are the factors that we identified here as significant. So 21.5% of non-dippers African American as opposed to 11.8% in the dipping group. So this was significant. Urine protein to creatinine ratio, 0.71 in non-dippers as opposed to about half of that in dippers. Sodium intake as measured by food questionnaires, about 4.3 grams per day, much higher in non-dippers as opposed to dippers. And interestingly, loop diuretic use it was also, there's only a select few of these patients who are on loop diuretics. Most of them are all non-dippers. And so then we looked at this in different models. We did both the univariable and multivariable models for both systolic and diastolic dipping. So this is a linear regression model here with our outcome being systolic dipping. And then we included variables here that we thought, based on our literature review, that we thought would be significant, and based on, of course, the cross-sectional analysis. And proteinuria here is protein creatinine ratio is log 2 transformed because it was a non-normal variable. So what we see here is that the things that we've identified red are significantly associated with systolic dipping. So specifically, African American race, a negative number here means blunted dipping. So African American race is associated with 2.6 percentage point lower systolic dipping as compared to other race. And then females as well had 1.1% percentage point lower systolic dipping. Loop diuretic use followed similar pattern, blunted systolic dipping here, associated with 4 percentage point lower systolic dipping. And sodium intake, this is in grams per day, is 1 gram per day higher sodium intake is associated with a small 0.1 percentage point lower systolic dipping. We did similar analyses for diastolic.
Sorry to interrupt.
Sure.
I think your slide is stuck on the distribution, the bar chart.
Oh, really?
Try resharing, may update.
Okay. Oh. Now?
Yes, looks good.
Okay. So, sorry, these were the numbers of the systolic dipping model. And moving on to diastolic dipping, similar analysis here and similar findings that African American race was associated with 3 percentage point lower or blunt diastolic dipping, loop diuretic use 6 percentage point lower diastolic dipping, and age here, interestingly, younger age, so 1 year lower age was associated with 2 percentage point lower diastolic dipping, or if we think about it the other way, older age, 1 year higher age was actually associated with greater dipping, 0.2 percentage points. So similar findings here between systolic and diastolic dipping, but some of these relationships actually appear more, appeared stronger for diastolic dipping. So my second question was really, what is the relationship between nocturnal blood pressure change and certain cardiovascular biomarkers? Specifically, is less nocturnal blood pressure change or blunted dipping associated with higher left ventricular mass index in these children? And our hypothesis is that yes, less nocturnal blood pressure change would be associated with greater left ventricular hypertrophy and higher left ventricular mass index, independent of other risk factors. And so what I'll show here is I've really, so far, my analyses have focused on left ventricular mass index. And so what I identified in looking at different spline regression analyses between systolic dipping and LVMI and diastolic dipping and LVMI. So firstly, the relationship between systolic dipping and LVMI was actually almost a flat line. So there really appeared to be no significant threshold where systolic dipping became associated with significantly associated with left ventricular mass index. Diastolic dipping, on the other hand, it appeared that less than the 50% threshold, there was actually an inverse relationship with left ventricular mass index. And so what I did here is I defined diastolic non-dipping as a yes/no variable with a cutoff of 15% and evaluated it relationship, the outcome, left ventricular mass index in linear regression models, with all of these variables also included based on prior analyses from the CKiD cohort that have looked at LVMI. And what we found is that even after adjusting for a number of these significant variables, diastolic non-dipping was associated with 1.35 gram per meter to the 2.7 higher left ventricular mass index. So key points here, African American race and loop diuretic use appear to be risk factors for blunted systolic and diastolic dipping. There are apparent differences in the distributions of systolic and diastolic dipping in this population. And it appears that the relationship specifically between diastolic dipping and left ventricular mass index is nonlinear. And there's, some question of what the threshold, is for actually for identifying these associations with outcomes between dipping and outcomes. So future directions, my next, some of further analyses will be looking at dipping and progression to end-stage disease in this population using Cox proportional hazard model. That will be next. I also am really interested in understanding if dipping profile is modifiable with retiming of blood pressure medication. So that's an area, I think, of future research, because if we identify that dipping is important, the next question would be, can we change it with changing blood pressure medication regimens? And I hope that will lead to preliminary data, and that in the future we'll have large randomized control trials to evaluate the long-term effects of modifying dipping profile on progression to end-stage disease and on cardiovascular disease risk in our patients with CKD who are at high risk for these outcomes. And I think, though I'm starting by looking at this in pediatric chronic kidney disease, it's widely applicable to other populations such as kidney transplant and even our end-stage population with regards to the cardiovascular disease risk. And again, hopefully we'll have more data to really explore the 10% threshold as we currently define it for non-dipping, and it's really supported by the data in this population. And I'd like to thank my primary mentor, Dr. Ix, my co-mentor, Dr. Garamella, all of my attendings in the Division of Nephrology, our collaborators from CKiD, Dr. Fur, Dr. Samuels, and all of my colleagues in our research hub of San Diego. And with that, thank you for your time, and I'll open up to questions.